Starting. All right, everybody, good morning. How's everybody doing? So our portion, is gonna be short today. We're gonna run for about 30 minutes. Trish has got a game for us, so we're gonna be playing. It is sepsis month. So once we get to 8:30, I'm gonna call the meeting pretty much at that point, and then we'll open up so we can start the game. It's like a Jeopardy game that we're gonna be playing, and we'll have an opportunity, so participate, and we'll figure out how to divvy up for the people that are online to get them onto specific teams. They won't be able to buzz in, but people that are present would be able to buzz. And then, if someone's on your team online, they can help with an answer. You feel free to text them and whatnot too. From there, I'd like to kind of just quickly open up. For admin, I do have Steve, Alvin, Kayla present. Steve, any updates from the admin side of things? Anything that's prudent?
I just purchased HealthStream for us, so $57,000 over 3 years. Does anybody work with HealthStream?
I have, yeah.
Yeah, so like an awesome education module, we'll be able to get so many resources and so many different modules and things to learn and see. And my goal is to try to make sure that everybody has the resources they need to be successful. If you don't know about hypertension, if you not familiar with certain codes or whatever it may be, to be able to get on there and look at things. So eventually what we'll do is we'll have the department directors assigning different modules to staff and departments themselves, just to kind of keep everything updated. And obviously evidence-based practice changes, things change, so we need to keep up with the times and do something that is more relevant to being successful in what we know and how we do things. So I just purchased that. Hopefully that will be starting within the next 3 months. We have to do the implementation phase. But it also offers like bedside support. So if you're on YouTube, or if you want to learn or watch or do a certain type of procedure, you actually can click on it and it will go through the different tasks for you. It'll show you videos on how to do it. Just a cool system. Actually networked with quite a few different people around the area. Kingman uses it. I know Wickenburg uses it. We're going to start using it. So there's a lot of different options. We looked at Relias, MedTrainer, and HealthStream, and this seemed to be it was the more expensive one, but it was the better one. And I didn't mind trying to go back to spend the money to make sure we get something that we're going to use and be resourceful. So a lot of new changes coming down the pike. Meditech is going to be implemented next year. Have to go through the kind of pre-planning and talk about, and we want you guys involved. So we're going to get some champions from the different units to be able to look at what would you like to see in the documentation. Is there something that will make your life easier? Is it better to interface, whatever it may be, right? In the ER, Pyxis doesn't interface with documentation, so that will be a good thing for them, So a lot of different things that we'll be able to have. Right now, we have 4 different systems, and we'll be able to integrate in one. You'll be able to see ER notes, ER will be able to see primary care notes. It's just more streamlined. At that coming down type 2, Paycom. Have you guys heard of that? So Paycom we're going to be getting soon. It's going to be a scheduling system that's way better than When to Work, but it also is going to allow us to get online and do like any W-2s, anything we want online. We can see our paychecks, we can change our status, we can do all kinds of stuff. It's 2023, so we've unfortunately fallen behind the times at La Paz, so we're trying to catch up. So yeah, a lot of cool things coming down that's going to be interesting, and yeah.
We'll get into it. First thing I wanted to start out with, so I did get in a official direction to move on with our inpatient transfers. So we do have GMR. I don't know what's their AeroCare, I think is what it's called.
Yeah.
Well, previously we were kind of open-ended on who we contacted first for our transfers. We've gotten official notice that we are going to initiate all of our transfers with GMR. A couple things I want to make sure that we talk about when we're talking about transfers with GMR. If you have a patient that is in urgent, rapidly deteriorating, needs to be on a helicopter, headed to a facility where they can get the help that they need very, very quickly. And it appears that you're running into nothing but delays with GMR, right? There's not like an immediate acceptance. It's going to be 4 hours before they can get the transport set up for that patient. And this is someone that's, rapidly deteriorating. They need to be, in a strip unit. They need to be, in Havasu getting a cath procedure, whatever it is that's going on with the patient. If there is any delay, immediately transition that over to Air Methods. They have a pretty good track record of being very, very fast for us. But we do want to initiate any of our standard transfers, something that can wait a little longer. Maybe it is going by ambulance. We want to try and progress those through GMR first. We're trying to give them as much of an opportunity as possible in the contract. Another key thing with GMR is, and Ida and I were talking about this yesterday, they do not have a PCS form. So when you initiate a transfer for a patient, the standardized form that we have to use for all transfers is the EMTALA, right? So that's any transfer with any patient with any transport company. Each one has to have an EMTALA, but some of the transport companies have their own documentation that they ask for us to fill out. So, for example, Air Methods has their own PCS form that we have to fill out. AMR has 2 PCS forms that we fill out for them. The AeroCare portion, the flight portion of GMR, does not have a PCS form. So the only thing we have to fill out for them is the EMTALA and, the classic print the chart. If there's discs, print the disc, get all that information assembled. But they don't have like a special PCS form. Apparently they do everything on their computer. So it's all digital for them. Their PCS forms are digital. So just bear in mind that when you do a transfer with GMR, there's not any extra forms that you have to fill out, just the EMTALA and then all the standard information that gets printed for them.
So just quick bullet points. We have a contract with them to fly out of the emergency department. It doesn't necessarily delineate that it's hospital wide. We're just trying to be consistent so everybody kind of follows the same thing. And it's not like, what do we do? Who do we call? So, and Keenan and I talked, just call GMR in the beginning. Again, like you said, there's an emergency and they're like, oh, well, there's supposed to be an auto accept, like, yep, don't worry, we'll take care of it, right now, but if they're like, hey, we need to call and wait for acceptance and, say it's an emergent patient needs to get out, if you're waiting 10 minutes, just call Air Methods, we're not gonna, we need to do what's right for the patient. I don't really care about a contract. If we've gone that route and we've called and they're not able to do it or they're delaying, we need to do what's right for the patient to get them to the right spot. So that's what we always have to keep in the back of our mind to make sure we're doing the best thing for the patient. So, yep, that's what I would do.
Next thing I wanted to get into, we're going to talk about shower schedules. So this is something that I was talking about with Denise. We actually had a patient that was here, I think was here for like a 5 to 7 day stay. And Denise had got a phone call from the patient's niece and had reported that the patient hadn't had any bathing care while they were here at La Paz. Now, including bed bath. So the patient hadn't had any sort of shower care or bathing care while they were here. So I kind of initiated a conversation with Denise. This is something that we talked about in the swing bed meeting last week, about the consistency of hygiene that we have for the patients in the hospital. Now, there's some differentiation between acute care setting and swing bed setting, right? Acute care patients oftentimes are going to be sicker, less likely to be able to actually get in and be able to take a full shower, right? Some of those patients may be able to, maybe they're here on observation for like a telemetry thing, right? They can still walk, they can still move, and they just need to be able to have the opportunity to have a shower. But sometimes you're going to run into those patients that are completely bed bound. Getting them up into a shower isn't necessarily the best thing for that person, but ensuring that they do have some form of hygiene care while they are here is prudent. It's part of the activities of daily living, right? That is something that we all learn in CNA school, nursing school. It's a prudent component of what we do on a day-to-day, right? And on top of that, we work at La Paz. I don't know how many of you here have worked in Havasu or Bullhead or Fort Mojave, the for-profit facilities, where trying to accomplish things like showers becomes extremely difficult due to the amount of patients that each person has, due to the amount of patients that each CNA is taking care of, right? And trying to squeeze in that with all the other things that you're trying to accomplish in a day is extremely difficult. We're better than that. We are better than those facilities. We have stronger, more capable individuals working here. And we want to do the best for the community that we have here. We have the capability to do that. And when we look at our patient experience, one of the biggest things that's involved in that is ensuring that they have an opportunity to bathe, right? So I did a little bit of digging, a little bit about my background. I came up as a CNA working in the Havasu SNU. And a big part of what we did, this is a skilled nursing facility, right? Big part of what we did was showers on a regular basis. We would do about 2 to 3 showers a shift. And each patient would usually get 2 showers per week minimum. And those are residents in a skilled nursing unit, right? This is all walks of the spectrum, everywhere from still bed bound because they had just had a hip surgery done earlier in the week, all the way up to patients that are nearing the end of their PT and OT experience. They're getting ready to go home. They're ambulating with a walker or maybe without a walker. But ensuring that those individuals had an opportunity to shower, whether we were using a Hoyer lift or a sit to stand, what have you, in order to get them into those areas to be able to perform that, right? One of the big things that we had a conversation about, and this was with Alvin and I, and Alana was at the meeting, the swing bed meeting last week, is that showers and patient hygiene is ultimately a nursing responsibility. It's not a PT or OT responsibility. This is something that comes from us that we do for our patients, right? In order to ensure that they have adequate skin care while they're in the hospital, right? When PT and OT are doing showers with patients, they are doing that along with interventions that are associated with that shower. It is an opportunity for them to help that patient achieve the highest level of mobility in the shower that they can, so they can do things on their own, right? To teach them new skills, to teach them new strategies in order to help them reach places they otherwise couldn't, right? So that way they can get fully clean. It's an education experience above all else. When we are performing showers as nursing staff, that's not necessarily our goal. Our goal is to get our patients clean, right? We're going to be helping them a lot more. If they are learning strategies from PTOT, we do want to try and help them do as much as they can on their own. We're propagating what they're learning through PT and OT, right? But the goal is that we get our patients clean, right? When you are laid up in a bed for 3-4 days, especially if you're incontinent, these folks end up with heat rash very quickly on their back, on their arms, on their legs, right? And one of the most efficient things that we can do to help prevent that is to keep people clean, to give them an opportunity to shower.
Let me just interject just for a second, because I could care less about a heat rash. It's the guys and the girls' dignity, right? I mean, who wants to lay in freaking stool? Has anybody been in the hospital lately? Anybody admitted or been in ER or anything? I was flown to Vegas probably a month and a half ago. Had no clothes, no car, no place to stay, nothing. I had nothing, no additional, no toothbrush. I didn't know I was gonna be sent out, right? I got there with absolutely nothing. Like, so when you lay there and you feel like helpless, and if we forget, I've been a nurse 23 years. Sometimes we forget how it is to be on the opposite side. it's an eye opener every once in a while when you get admitted or you get seen or you're in the ER or something, you know, like, oh my God, sometimes being a healthcare individual, you know too much, right? I'm like, oh God, what are, you know, they're talking about putting a pacemaker in me and like putting this thing, a Holter monitor that's implanted under my skin for 6 months to figure out if I have some great, I'm like, my God, like another time about nephrostomy too, because I had a kidney stone that was obstructed and like all this starts running through your head and it's super scary because you're the one helping at first and now you're the one getting things done to you. Just put the patient first. Know that this is someone's mom, dad, husband, wife, whatever it may be. You got to do the right thing for the patient. No one wants to sit there. It's a job to us, but on the other side, when you're a patient, it's their life, it's what they're living, it's their day to day, it's them feeling like crap and them, you know, being in pain or laying in stool or can't walk or new hip fracture, scared to be in there. There's so many different reasons why all this stuff happens, but until you're on the other side, it's kind of one of those things that slaps you in the face and you're like, oh shoot, you know what? These are people. It's not just a job. It's not just a checkbox. It's not just a, oh, I've done my due diligence for today. I get off in 3 hours. You know, you're taking care of these people. And sometimes I think we forget. And it's the same thing when we talk. Sometimes we write, you know, with all our abbreviations and we talk about hypertension and diabetes, all these terms that people are like, I don't even know what that means. You just said a whole sentence. We talk it every day. We know it, we understand it, we live it. We have to take ourselves back to the basics of being able to care for someone because their dignity and their upholding their respect as a human being and not letting them lay in feces and, you know, I need to go to the bathroom, just go in your bed and we'll clean it up. Like I would be, if someone told me that, I would be so mortified. I wouldn't know what to do. And I don't know if that's said or not. I know I've heard it before. But just go back to remembering that this is someone's family, like you're actually caring for a human being, not like, you know, a cadaver. I mean, this someone's, again, if you haven't been in the position, it really humbles you to go back to remember, you know, that this is the actual human being you're caring for. And so, yeah, all these things happen, and I'm not saying what Kean's saying is wrong, but at the end of the day, you're just, it's a person. Yes, they'll create rashes and bed sores and infections and sepsis and everything else that could occur, but it's a person. It's someone's mom, dad, brother, sister, uncle, whoever it may be. And that's the heart of why everybody got into patient care. I don't care if you're a nurse, CNA, PCT, PT, OT, it doesn't matter. You got in to help somebody. So when we forget about that and we go back to, yeah, you know, I got too many patients, it's this, that, you still got to treat people as a human being. So I just wanted to say that because me being flown out kind of struck something that you're like, oh shoot, that's right. These are real people you're caring for. You know, sometimes you get complacent and come to work and just do your, you know, 7 to 7 shift.
So we talked about some concepts for some different recommendations for schedules. And I haven't set anything in stone. I wanted to make sure that this is tangible and something that we can change to fit best with what we have. Probably the biggest question burning in people's heads is well, are you going to have enough people to be able to pull this off? Okay. And we will. I've got more aides coming. The first one actually starts tonight tonight. On night shift. And there's a total of 3 that are on their way to be rolled out, 3 additional CNAs. So we do have more CNA staff coming to be able to assist with these kinds of things, okay? I did get, this is an example of the shower schedule that they use at the SNU. I used to work off of this shower schedule. So this really hasn't changed since I worked there back in 2015, okay? The way that these schedules were set up is intended to try and space things out so you have enough time to be able to accomplish everything in a day, right? And the way that this schedule that they have works out is they do about 2 to 3 showers per shift, and each patient gets bathed at least twice a week. Twice a week. Most of us probably shower on a daily basis, right? So this is a very low goal, right, to be able to achieve for people. A lot of patients aren't going to be here much longer than 3 to 4 days unless they go to swing status, right? In which case they'll be here much longer, right? Alvin actually sat down with Alana yesterday and they came up with a concept with the shower schedule, using our room assignments to kind of put it into perspective. And again, it breaks down depending on how many patients we have in the department, breaks down pretty similar to about 2 to 3 showers per shift. And then about 2 showers per week per patient, right? I want some input from you guys on this. This isn't something I'm just gonna say, you know, we're rolling this out on Monday or anything like that. And we are gonna move on just because we're short on time, but it's something I wanna get the gears turning on. We are going to start talking about this in IDT meetings. I'm gonna start asking about when is the last time this patient had a shower, okay? Another thing that we're gonna get into, and we may not have enough time to cover it today, but I'm gonna start asking about how many times has the patient ambulated today. Because I wanna see some changes in our strip and mobility as well, right? Again, you may be thinking to yourself, how do I have enough time to pass my meds, do my assessments, accomplish these things? I do have more help coming. There are more aides coming to join the team, okay? The shower schedule that Alana and Alvin got together and worked on, intentionally has more showers taking place on night shift versus day shift, because we want to see more activities happening during the daytime, particularly for swing patients, which means our aides during the day shift are going to be doing a lot more moving patients from their rooms down to the ICU lobby and back to their rooms again, right? Which is a lot more movement, okay? But again, like I said, this isn't something I've set in stone. I just want to initiate the conversation about this. Okay, this is something that's very achievable for us here. Very achievable for us here. We can accomplish this. We can be better than the other facilities that are in this area. Our people are more than capable. Our reputation is potentially even on the line, right? Based on what we can perform while we're in the facility. And don't forget, like Steve was talking about, these are people that we're talking about, right? It's important that we give them an opportunity to maintain their dignity while they're in the hospital. And if it was me that was laid up in a patient room, bet your ass I would want to shower at least twice a week, right? You know, you start getting you know, I sweat a lot. I start getting stinky after about 2 days. I don't know about you guys, but you know, I would be very, very self-conscious about being around even nursing staff or aid staff or PT and thinking like, do I stink? Do I smell? Right? Feeling sticky. I can't sleep when I'm sticky because I sweat too much, right? Just keeping that in mind. So this is going to be something, yes, go ahead.
So like, I feel like I can already see people's body language, like we do a lot, so it's like, there's all the showers that we do, obviously you hear like only one negative comment and 100 out of 100 positive that you did, whatever. So like, for instance, as the nurse, like, all 3 of my patients yesterday had the opportunity to take a shower. 2 of them chose to take a shower, the other one didn't. And that was a choice, and then it's charted and we move on with our life, right? Whatever. It's a new day today. We'll offer the shower again.
Yeah.
But what I see with that, it's like, say, for instance, if somebody comes on Sunday night and their shower day was Sunday day, and then they leave on Wednesday morning, if you're still gonna kind of have that same problem with
Fall into the
they
gaps.
fell whatever room they had, do you know what I mean? Where I had said, I feel like whatever day that person goes to swing, maybe those shower days are determined by whatever, kind of like, say, if they're a Monday, Thursday, say today, whoever rolls to swing, their showers kind of become a Monday,
That's
Thursday.
schedule. Yeah.
Versus, and then the other people, I feel like as nursing staff, we should be offering those showers if they're inpatient daily or split them up shift wise, but you still offer them the shower and then you document if they choose not to. Because I think with inpatients to have a set schedule, it's gonna be hard because there's some people that just get here, like my two ops people that were here yesterday. They were like, yeah, I want a shower. It was like 8:30. They ate their breakfast and they were in the shower, which is totally fine because they were ambulatory and the guy had just worked all day long, fell in the parking lot, had chest pain, like came to the hospital, was like, dude, I literally worked all day. We're like, yeah, like, let's take a shower. So I'm not gonna be like, oh yeah, no, today's not your shower day.
And that's,
You know what I mean?
Yeah, you'll never
No.
take anybody down if they're asking.
But do you know what I mean? At the same time, when we get so busy, we're gonna focus, I just think we're gonna focus on like, okay, these are my showers. So I'm gonna like, these are my set showers.
and that was
I think for
1/8
inpatient,
yesterday.
for inpatient, I don't feel like a shower schedule really.
That's why I think Keenan wants to have that conversation and just say, listen, what are your guys' inputs? What are your guys' thoughts? You guys do
This is what I want to hear.
makes sense. This is what we did. Here's some ideas. You know, I mean, take it and incorporate it and kind of make it your guys' own thing. And I think he's just saying, let's start the conversation to figure out how to make this.
And this is what I think would work because, okay, showers is fine. Yesterday we had 1/8. I think the algorithm, change the algorithms to our PCTs because they get burnt out. The one that's coming gets burnt out. I think this is our third time coming back. So maybe instead of, oh, at 10, we get 2/8, maybe lower it down. Because during the winter and even right now, they are hard patients. And sometimes we're stuck with a 1/8. So
Or
yeah,
not,
let's give them the best care
a lot.
and showers, but it's a lot. It's a lot of work for just 1/8.
But are nurses not helping? I mean, I'm sure they are. I mean, they got meds, they got sections.
Also.
Well, I mean, that's the exception. If you're short-staffed, it's a different story. But if you're staffed and, you know, I mean, you got an 8, I'm sure everybody could, you know, jump into.
No, yeah, when there's,
No one wants to be short-staffed.
Yeah,
That's our
we-
goal, obviously, is to hire. We're paying more. We're trying to do all this stuff to recruit, you know, people. So we don't want to be short-staffed. And I think we're getting to the point where I think it's been better. Now, a couple of slides in, though, we talk about call-offs, because that also can make an impact whether you're short-staffed or people, you know.
And
Following
then
off.
we're also, I was gonna talk to get with PDS, we're gonna be giving more and more showers and having more of a schedule. Because they're gonna have to come and clean that shower between each use. Or sometimes we'll be like, hey, can you clean the shower? And it'll be like,
oh,
depending on who it is, it'll be a
and
while.
it was
So
not
then now
yesterday,
that
because
we're-
we didn't tell his employee that 2 people discharged. I'm like, we never do that. They come up, they see the board, they know that it's a
Yeah.
splash, they know that they're gone. So I don't think I have to go chase one of his employees and say, hey, by the way, that room is empty. Like, no, that's not my job.
Yeah, we can handle that part.
Yeah.
Back to the showers. Do we have declination forms, like when patients don't wanna take a shower?
I don't think it's that
Yeah.
serious.
Yeah.
I would just document it. They just decline shower at this time. You know, yeah. It's not getting anything or anything.
Yeah,
I don't
that's
wanna
another
shower
issue.
at
Usually
midnight, I don't wanna get up at 5.
Yeah, because that's the time they'd have to get up, because at 6 o'clock, they're all busy, they're giving meds, and then the CNAs are busy getting people up and getting them dressed and whatever.
When I did my.
So I
clinicals-
agree with Ida that, yeah, you should bring the census thing down so that we have 2 people. And because it's gonna get busy very easy.
I mean, not everybody goes to bed at 8, right? I mean,
Yeah.
there's people
No.
stay up, but I mean, again, you can't. It's not as like stringent as like, oh, 8 o'clock, you're here, you know, again, you know, it's one of those things where sometimes people stay up till midnight or 11 or 10 or, you know, 6. Some people go to bed early, you know. I think it's one of those things where that's where you kind of have to figure out. I think the pressing part here is figuring out how to just make sure people get showers, right? I mean, that's the end of the day. We need people to get showers, so we want them to feel good, make sure that they feel clean, you know, help them from a healthcare standpoint, so they're not getting an infection. So again, it doesn't have to be regimented. Oh, she takes everybody at the shower, stand in the line, we're gonna hose you down, you know? It's just the fact that we, I mean, run through the decontamination, okay, yeah, so it's just, we gotta get them showers, we gotta figure out how to be able to make sure that they're clean, you know, so. That's the conversation that everybody needs to be engaged in and just say, how do we do this? How does it make it work? Because I don't think it's a set in stone that has to be done at 5 or 6 or, you know, I mean, the point is we gotta get it done. We gotta figure out how to do it, so.
We want achievable goals here.
Yeah.
That's what we want to try and establish, right? We know why we want to do this. right? We know that we can do this. It's just, what kind of goal can we set that's achievable, right? And kind of like the government, setting a minimum expectation. That's the purpose of a shower schedule, right? If you go above and beyond that, and a person's getting shower every single day, that's amazing. You know, the reason for putting something like this in place is just to kind of set the minimum expectation, right? And we're going to do something with the showers. That's happening, right? What I want is I want the input to make it achievable, to make it something that our team agrees on, that comes together as a consensus between our day and our night shift to come up with something that is achievable so that we can accomplish this for these people, okay? We want to be able to have a day-to-day. When I come into work and I think about how I program my day out for myself. You know, I pass my meds at this time, I do my assessments at this time, right? To be able to work this into that so that it is a normal, at the front of your brain, something that you're thinking about. Where am I squeezing in a shower for these 2-3 patients today? What time are we gonna accomplish that? You know, if this person says no, is there somebody else I can offer that time slot to? You know, so that way someone else gets an opportunity, right? Does it make sense to have a set schedule for inpatients versus inpatients? Those are the kinds of conversations that I want to start here. So the wheels are turning. I appreciate the input. That's exactly what I wanted to do here. I wasn't going to come up with, hey, we're rolling something out on Monday. I just want to start that conversation. So.
And I mean, at the end of the day, it's gonna be teamwork too. It's not just
Yeah.
their responsibility.
Absolutely. Of course.
Like I was like, hey, can you get the shower ready? I walked the patient down, literally showered themselves fast. Like it took us. what,
That's
2 minutes?
ideal. Yeah.
It was literally like, get the shower ready, I'm disconnecting them, I walk them down, they take a shower, and then they walk.
Can I say something? This is Dawn. Erica, you hit it right on the point. I think the nurses need to help out the aides a lot more. Since I've been at La Paz since 2015, there's been so many times that I've seen nurses sitting at a cow charting and they go ask the aide, hey, did you empty that? Can you go empty that Foley in that room? I think that's absolutely ridiculous. I feel that the PCTs and the CNAs are there to help me. They're aides. They're there to help me if I need help. But if I'm in a room and my Foley's full, I'm gonna empty it. You know, if there's a dinner tray sitting there, I'm gonna take it out. That would give the CNAs and the PCTs a lot more time to do showers and stuff. I think we all need to do better at teamwork and not saying, oh, that's the CNA's job or that's my job. It's not. As the nurse, it's your responsibility. That patient is your patient. And everything that's done with that patient is actually your responsibility. And that's just how I feel. I just wanted to get that out there.
Steve, you're right. That's exactly how it should be. I mean, people are here to assist. It's not your job, my job. It's everybody's job to take care of the patient. And I know that sounds generic, but you know, at the end of the day, we're here for the patient. And again, this is peer-to-peer accountability. You know, I mean, if you hear someone say, oh, go do this, you know, and then they're just sitting there chilling with their legs up and you're talking about their outfit, you know, while the other person's working hard, you can say, hey, listen, Steve, you know, I mean, you could probably help with that Foley, you know, I know it's your patient, you know, I know nobody wants to strike up, you know, any type of, you know, problems with coworkers, but it's not really that. It's just saying, hey, listen, you know, I mean, Steve's working hard over there. Is everybody, you know, do you want to go help him or do you want to do this? Or, you know, I can help if you're busy or I don't know. It's just one of those things where you sit there and watch somebody get hammered all day long and never say anything. Everybody has to say something too, you know?
Agreed.
We're gonna rapid fire a couple things. So, this is something that we're actually gonna talk. We're gonna do a separate charge nurse meeting. This is something that we'll bring up there. We're gonna talk about. We had a Code Blue RRT meeting yesterday. And just a couple of ideas. So this is something we'll be talking about, Amanda, and any of my other charges that are on. We'll be kind of discussing this later on in a charge nurse meeting, and then I'll disseminate the information to the rest of the team. This is not something that's taking effect until I have a conversation with you guys. We talked a little bit about this kind of goes right in hand with the showers. Like I said, this is something I'm going to start asking about at IDT, ambulation for patients. Probably one of our biggest proponents for this is Dr. Lee. You probably hear him at least during a daytime IDT, he talks about ambulating patients all the time. And there's very good reason for this. Basically by day 3, if a patient's been laying in bed and they have the capability of getting up and moving around, the amount of decompensation, increased risk for pneumonia, pressure injuries, and other issues starts to increase significantly the longer that that person's laying down, not moving, right? If they have ambulation orders, we want to be able to give them an opportunity to get up and walk, right?
Can I clarify that per day? From a PT perspective, if we're working with a patient and they're safe to mobilize, we want to put that up on the board, and we're gonna do a better job of communicating that with you guys. In the past, we've looked at 3 times a day. I think that's difficult, you know, and they're already getting rehab too. So we've sort of adjusted what we've been recommending a little bit. You might have noticed on the boards, once per shift. I think that's a little bit more doable. And my hats are off to you guys. You guys are taking care of these patients 24 hours a day, 12 hours a shift. As a rehab, you know, staff, we're in there for an hour to 2 hours a day. You know, so my hats off to the care that you're giving to these guys. And I just want you to know that when we talk about teamwork, we do not exclude ourselves from that. I hope you feel that when you guys are, you know, trying to clean someone up, if we're in there, we're helping them to roll, we're helping them to move. We're trying to make sure that you guys feel the support of the rehab staff while we accomplish a skilled service. So appreciate what you guys are doing. So
we'll talk about this a little bit more later on too. I'm looking at some tools that we can use. Alvin was showing me some stuff that the Johns Hopkins Hospital is currently using that makes it easier to evaluate a patient's mobility. The key thing is that ultimately at the end of the day, a patient's mobility is not necessarily determined by your physical therapy and occupational therapy department. The ability to get a patient up out of bed can be done by a nurse, an aide, a PCT, right? There are tools that are in existence that help to make this easier to be able to set goals for patients and to be able to evaluate where that patient's currently at. It makes recommendations on the equipment that you should be using in combination with that patient in order to achieve that movement, right? But being able to go into a room, sit a patient up at the side of the bed, see if they can stand, see if they can take a couple of steps, does not take someone with a master's level education to figure out, right? Any of us can do it. When I was working as a CNA in the SNU, I had patients all the time. I had no idea what their capability was. I can figure that out, right? I am fully capable of figuring out if they can sit on the edge of the bed, you know? So use your tools, use your ability to evaluate those patients. And then when you see something, trigger that PT consult, you know? Initiate that movement, trying to get that patient up. If they can't roll, that's a pretty good indication they're probably not going to be able to sit, right? If they can sit, but they keep trying to pancake or flop over, they're probably not going to be able to stand, you know? And you initiate a conversation with them briefly and you ask about, well, what's their history like? How do they get around at home? Well, I walk around at home with my walker and my cane all the time. I go on walks with my dog. And now you can't even roll over. That's a PT consult. Absolutely. It's written all over. So use your training, use your ability to evaluate. It's pretty straightforward, something that all of us can do to figure out the capability of a patient, right? And then have that conversation with them, figure out what their home life is like. If their home life is that they can't roll over at home, we're probably not going to get them much beyond that while they're here. We might be able to, but if that's what they've been doing for years, that's probably what their baseline is at home, right? Something that's come up a lot recently. If you call off, call the unit first. Don't call me first. Call the unit first. It is most important that the staff that is here, right, knows what's going on, who's going to be here, who's not going to be here. That is critical. Call the unit first. Let me know second, okay? I'm not always here. I don't always answer my phone. Easiest way to help prevent miscommunication as far as who's gonna be here, who's not gonna be here, is to communicate that to the team that is present at the hospital. Okay, so please call the unit first and then let me know. And it's perfectly fine to send me a text message. I'm fine with that. You do not have to call me on the phone. You can send me a text message. Just make sure that you're notifying the unit
You
first.
want to talk to the charge nurse, Bill?
Preferably if you can. Okay, just because that person is the one that's going to be making decisions as far as how many patients we're taking on the unit, right? So that decision-making process is inherent within the charge staff, right? So we want to make sure that they know what's going on first.
Do the call, but just in regards to communication, like with you and the nurse's station and stuff, we've been having a lot of situations where people will talk to you regarding to what days they're, they switch up the schedule or something and we're not aware.
Same thing.
Possible to just have that person notify us or you give us a heads up, just send a text message through the nurse's station phone or something, because it's caused a lot of confusion when we put somebody on call or when we don't put somebody on call and suddenly we have to move staff and somebody has to be sent home. And a lot of these guys come from Havasu or it's from further. So it's just if we could help that.
Same thing. If you have a conversation with me about making a schedule change, let the unit know. Okay, absolutely 100% of the time. All right, let the unit know. If I've cleared it, let the unit know. Quick text message to the med surg phone, especially if it's something that's coming up within a couple of days, let them know. If it's 2 months in the future, that's a different story, right? But if it's within the same week, let the unit know what's changed, okay? That way we can make sure that we keep the communication on keel. I messed this up. This with me in class is on Friday, the 29th. Okay, so I gotta fix some stuff today. I will fix that and I'll loop back with you guys. I talked about, we do have 3 new full-time aides coming. First one starts tonight. The other 2 I have Anthony Daffer and Valerie Mans. And they're coming in the near future. And then I also touch base with Regina yesterday. I've got 3 nurses that are starting too. But I still need 3 full-timers for night shift. So if you guys have contacts, let me know. Let me work on people. I need numbers. I need names. I need people I can try and influence and try and get to come down here.
Did we get a bonus? Favorite.
Where'd Steve go?
Just like.
I'm like, oh, money buys.
Since for people.
All right, Trisha, let's get you off the ground.
So you're totally fine.
So as some of you know, September is Sepsis Awareness Month. And this year, up to a couple weeks ago, we had 51 people come through our ER who were diagnosed with sepsis. 26 got shipped out. So we're trying to make sure that we know what someone who has sepsis, what the steps are, so that as nurses, we can be aware and make sure the physician knows. So we're going to play Jeopardy. So this group is a team. This group is a team. So just like in Jeopardy, everything is in form of questions.
Since you don't have half a brain right now.
Trisha, I've got 10 people virtually too.
I don't know what to tell you.
Okay.
Okay, so here's, I'm giving you cheat sheets.
Okay.
Thank you. We're a little
I
tired this morning.
figured that they might be useful unless some of you are sepsis experts, which is fine too. That would be great. So we also have, I also would like you and the folks that are virtual, I will give you these and then they can come to you. I'd like you to choose as nursing staff, and it will be all of the nursing departments, who you think would be a good sepsis hero. meaning they're the ones who pick up on sepsis. They're the ones who do great assessments. And they will get this lovely pewter pin that's made by a small company, and it says Sepsis Hero. So if you will nominate, you'll pass those out. And then one more thing. If you care, you can put your name in for a sepsis warrior. I'm going to give these out so that you can see how bad sepsis is worldwide. It is not just a La Paz County problem. It is actually a real health issue. We also have badge buddies. If you'll each take one, gives you the, I'm sorry. They have the symptoms, so there's different levels of sepsis. And then on the other side is RAS for agitation. Okay. So we only have 2 teams and we start. So which, we'll have this team start, so you can choose what you would like first.
Charge nurse Samantha. Y'all, what would charge nurse Samantha do? I don't know.
Just pick one.
Let's do 200. 200? Yeah. I'd pick
What?
impact.
Impact for 200,
Yeah.
team 1. All right, so when you have the answer, hit the buzzer. There's a cheat sheet.
Oh, I don't get the question.
All right, so do reveal the correct response, please.
Just gotta give me a second.
So this is who's higher. Risk.
See, that answer, you answer with a question,
Yeah,
okay.
it's like regular Jeopardy.
Okay.
All right, then we go to
Well, that was the
continue.
answer. She can show us. Yeah, she showed us the answer.
All right, pick team 2.
What's in a name, 100?
Did anybody guess on that one?
No.
Okay, that was our example.
Yeah.
So not good at Jeopardy?
Team 2 got first. So what's the answer?
Systemic inflammatory response syndrome.
Good job. And so that's team 2. All right, let's move on. So team 2 gets to pick
Statistics
for
200.
some of these, you'll have to use critical thinking skills or the other cheat sheets.
Oh,
All right, time's up. So you want to reveal since nobody got it? Reveal the correct response. And with COVID, that statistic has changed. COVID is the 5th leading cause and it usually causes sepsis. Next, let's see, let team 1 go.
Treatment for 100. 87 set of orders.
It can be close. Just put it in the form of a question.
Oh, I just watched it. You said fluids, right?
Yeah, whoever. Oh,
Yeah,
so,
fluids. What is
okay,
fluids?
so,
What is that?
and we do have one here in the ER. Okay, so,
Are we giving points?
yeah, no, nobody got it. Team 2 is wiping you guys. So, team 2, go ahead.
Yeah,
Choose a category.
We're all night shift together. We don't have brain.
we all
breaks.
worked last night. We're like,
Treatment for 200.
Oh, I mean, of course you would want IV times 2. What is IC?
Hey, hey,
I don't even know what kind of question to answer that.
I know.
What you got?
what you got? What's the answer?
What is true? We need 2 IVs.
Right?
So it might be close, so let's see what the reveal the correct response is. So that was. Yeah. All right, so we'll give you team 2.
We know, point being, we know we need 2 IVs.
Right,
Yeah.
all right, so we'll give team 2 there. Okay. Team two, pick a category.
Impact 100.
What is symptoms possible?
Yes.
I knew it was harder.
So
I know.
what's the answer?
Symptom of possible sepsis.
Question?
Frame it in the form of a question.
What is
symptom of possible?
Let's see. Yes. All right.
You gotta be quicker. The one time.
So team two gets to pick a category.
Getting wiped out.
Pathway 100.
Oh, what is Sears?
Let's see. The sepsis screening. We'll give it to you.
Yeah. we do
We'll
our
give it
serious
to you.
assessment, Yeah.
Oh, focus.
All right, team one, pick a category.
Let's do pathway for 500.
Jeez. Trying to catch up.
I know.
We did it, we did it.
One did it, they got it. So what's the question?
What is
blood culture?
Yay!
Oh, like, hit the buzzer.
Team two, yeah, so hit it hard. Okay, so team one, pick a category.
What's any name for 200?
What is, no, hit it. What is serious criteria?
Good job.
I'm gonna need the buzzer over here.
Okay, so it was correct. So team one, pick a category.
Oh, something hit it. Oh.
That'd be you.
Oh, okay, I'm off. Let's do treatment for 300. Antibiotic started in one.
What is a procedure? Cultures?
Just.
What is hit it?
And then what is the question?
What is the culture?
No, I was thinking, what is a broad spectrum
That's
antibiotic?
part of
What are
the,
you saying?
What is a
Order
broad spectrum
set.
antibiotic?
is the,
Oh, what is required to pass CNS?
So sepsis is one of the things that CMS tracks to see what kind of hospital we are. So it's important that you all know. Okay,
Team two.
team two, please.
Impact 300.
what is broad spectrum antibiotic?
Let's see. So when people come in who have, that we suspect have bacteria, but we don't have the cultures back yet, you need to keep a close eye on them. We have a lot of, valley fever here, it's fungal. So we just need to be aware so that we aren't ignoring things. It's like, we don't know yet. That's our job, is to be aware. Okay, so
Team two
team
again.
two, pick categories.
Statistics 100.
Team two,
What is debts?
that's a lot. It's 40,000, is that right? Is the math right? Per state. Okay.
Statistics 300.
Yeah.
What is mortality rate for severe sepsis?
Good job. Okay, team two. Oh, we're tied.
Tiebreaker, so we know.
Oh, from the.
Team two, pick a category.
Statistics 400?
Multi-organ dysfunction.
I know, like, trying to stay awake.
Yes,
What is sepsis?
I bet you're right.
Severe sepsis.
So that's on the back of, that's on your card, on your badge buddy, so that y'all know when you pull them so that you can decide. Okay, team one, pick a category.
Let's do pathway 400. No.
Yeah.
Team two?
What is 6 hours?
2 hours.
So you get somebody from the ER, they came in, we started the sepsis assessment at 2 o'clock. They come to the floor, where are you doing your second one?
By 4.
Right, right. Okay, so team two, team
We
one,
got it wrong.
team one. Pick a category.
Let's do 300 and what's NA?
Team two,
What is sepsis criteria?
close enough. Okay, so team two, pick a category.
Statistics 500.
Ooh, they're going for broke. Team one,
What is the cost from sepsis?
so when they come to the floor, it's important that we check to see, did they get their antibiotic? If another one is ordered, because they give broad spectrum in the ER, and they may give a more specific one, we need to make sure that we don't delay, because mortality goes up by 7% for every hour. Okay, so, team one, you got it wrong. Team two, pick a category.
Treatment 400.
What is broad spectrum antibiotic?
So,
It's
so we don't want to give antibiotics before the blood culture is drawn, because it messes, obviously.
you'll get like a false.
Yeah.
Right, right, and so we don't want to do that. It's always important. So when you read the S bar that comes across, check to see, because it always says, you know, no, they didn't get antibiotics, but when you're getting handoff from the ER, make sure you ask. Because sometimes for whatever reason, that, so that we know and that the hospitalist knows. Okay.
And then we always check just a quick, on the Pyxis, it will tell you if it's been pulled or not.
True, true.
So whatever they gave, if it's never, I give it,
Yeah,
if
absolutely.
it's ordered.
Absolutely.
If it says given at whatever time, then I'll put, you know, on our mark, given an ER.
Right, right. And because when I do audits, I see that frequently. Who?
Team one.
Team one, your turn. Pick a category.
Halfway for 200.
Team two.
What is organ dysfunction?
I have no strength.
You put in 12 hours. Okay, team two, pick a category.
Pathway for 300,
Team two.
6 hours. What is 6 hours?
Okay, so whose job is that? Whose job is it to track? Whose job is it to make sure it gets done?
Yeah.
The nurse.
Yes. Thank you, Dawn. Team two, pick a category.
Treatment 500. Oh, hit it.
Team one did catch.
What is broad spectrum antibiotic?
Finally.
It's like after.
If you don't know what a broad spectrum is, if you're not sure, you can always look it up and make sure. Because it is important that we do that, and it's usually done in the ER. Okay, all right, so team one gets picked a category.
What's in the name for 400? What is lactate greater than 2?
Just as that.
So this is what causes death. And if there's not a lot that can be done, so what is the best outcome for that?
After the target, so.
Good job. All right, team two, pick a category.
What's in the name 500?
Team one, or team two, I'm sorry.
Multi-organ dysfunction.
I,
What is multi-organ?
thank you. And that is true. And that moves us into which category? When we start having organ dysfunction?
Severe sepsis.
Good job. Okay, team two, pick a category. Ooh, they're going for it. Team two,
What is cause of death from sepsis?
so sepsis causes hypoperfusion of organs, which then leads to organ dysfunction, which then leads to severe sepsis and MODS, and then they go to heaven, hopefully, if that's where they're going. All right, team two. Yeah, sure. So,
Oh, my goodness.
team one.
What is response to sepsis?
Good job. Good job. Okay, so this was very close. I hope it was fun and educational. So, so please do thoughts about the steps that are the, thank you. And here's for the bag, if you are interested in being part of that drawing. But please do some real thought, because the expectation, once we do the drawing for, the sepsis heroes and we do an evaluation, we really will look to them as champions on the floor and in the units, because, in my head, when I've done chart audits and stuff and see people get sent out, sometimes it is because we have missed things and we're not assertive enough.
Tricia, when are we doing the drawing?
End of.
End of the month?
Yeah.
Okay.
So if anybody from, cause I'll give you these. If
That's
we
what I was
have,
asking.
yes, so those of you, I appreciate, those of you who were on remotely. And if you're interested, I'll give Keenan, so that if you're interested in the bag drawing, you can do those. And I really would appreciate your, input on who you would like for your sepsis hero on your units. And team one, I'm so sorry, you didn't win. So team two, we each take something to commemorate this lovely
Win.
yes.
Participation trophies.
So I raised my kids if you participate and get bruises. So, yeah, no participation trophy
We
for
don't,
you.
we don't want me dead like anything. Don't come give us a badge.
But you did, hey, you got your badge, buddy. I consider that kind of a participation trophy.
No, I like these, I like it. Now it is a participation trophy.
Well, make that a participation trophy.
I'm really sorry, what are these my strong colors?
Those are for the back drawing.
Oh.
So if you're interested, please put your units. I try to remember everybody's name, but I'm not always that good.
One Band-Aid for all the crybabies. Look what I was.
The entire site. You look. I am.
So it was fun, huh? Absolutely. And now I need to figure out what to do for folks who are remote.
Yeah.
Oh, did I give you their badge?
All right, everybody.
Okay.
Anything else? Last minute, anything else anybody needs to contribute meeting wise? Thanks for staying on, guys. I appreciate your participation. And I will have the video posted later today.
I know. I really appreciate your input. Yeah.